Hi everyone, it's Dr. Towfigh. Welcome to Hernia Talk Live, my weekly Q&A. I'm very excited to have you all. Today we will be talking about some very common problems, but I know that a lot of questions arrive. Thanks to everyone who are joining me on via Facebook Live and also via Zoom. I'm also on Twitter at HerniaTalk and on Instagram at HerniaTalk. And many of you know that we are, I think, on episode 86, if I'm not mistaken. And all of those episodes are available on my YouTube channel. And we've talked about so many amazing topics. So today's topic is discussing umbilical hernias. I do that because sometimes I feel that we talk about so many rare things like mesh infections and nerve injuries and so on, which are all very important but not common. And yet sometimes we don't talk about the most common operations, the most common hernias. So as you may know, about 3 out of 4 hernias are inguinal, so in the groin. So the typical indirect inguinal hernia that goes down to the scrotum in males, and there's also the direct and femoral hernias. The other 1/3 of hernias are in the abdominal wall. Those we call umbilical hernias. If it's at the belly button, it's called a ventral hernia, which is like a general term for anything in the abdominal wall in the front. If it's in the upper abdomen in the middle, we call it epigastric hernia. There are things called Spigelian hernias that are just very uncommon hernias kind of below the belly button, usually in towards the side a little bit. If your hernia is after an incision, like a surgical incision, regardless of where that is, that's called an incisional hernia. And these terms are important because the diagnosis is important. The diagnosis is important, and also the treatment is very much related to that diagnosis. So umbilical hernia specifically refers to anything at or just right around the belly button. It's an Audi. So if you see an Audi belly button, that is an umbilical hernia until proven otherwise. I go on Instagram a lot, and I feel that so often we have like models and so on, and then they put themselves on Instagram, whether male or female, and my eyes go straight to the belly button because like, oh, that's an Audi. Oh, that's a hernia. Maybe I should fix it, make you look better. And then of course I get hate mail from people that are saying that I'm shaming people for having an Audi belly button, but just know it's a hernia. It's actually a medical problem. And even though it's uncommon to have a lot of complications from these belly button hernias, some people do, and so it is actually a medical problem. So one question that's being asked is, I have an umbilical hernia 1 centimeter, but it's not an Audi yet. Yeah, that's very possible. So a lot of people will get imaging. Maybe they'll get a CAT scan for some other reason, gallbladder, or they had a car accident or something, and they get a CAT scan. And then as part of that imaging, whether it's ultrasound or CT scan, or less commonly MRI, it will say 1 centimeter umbilical hernia with fat content or something else of that sort, and you never knew you had an Audi. So if you look at your belly button in a mirror, it should be an Innie, so it should be like stuck inside, and it should be symmetric. So all around the inside of the stalk of the belly button should all look the same. If you look in the belly in the mirror, and you see that there's a little bit of outpouching on the side of that stalk, and therefore it's not completely symmetric, then you probably have a little belly button hernia. Of course, those tend not to be a problem. I'm just saying if you want to like be very clear about it. So someone here is saying that yeah, in fact, they were diagnosed with an umbilical hernia through a CAT scan and an ultrasound, but it's not an Audi yet. An Audi is when the hernia is not on the side of the belly button, but right in the middle and things protrude out and you get kind of like an Audi belly button as opposed to like a sunken in umbilicus. The question is, does this cause symptoms? And it looks like someone already is telling us online that they do have pain, and sounds like that's why they got the imaging. The CT scan and ultrasound both confirmed a 1 centimeter umbilical hernia or belly button hernia. So in general, small umbilical hernias, by small I mean under 1.5 to 2 centimeters, which means less than an inch. If you have no symptoms, most of us do not recommend that you have it repaired because the chance of it causing you problems is low, but then there's a chance you'll have complications from surgery. And so you don't have to have those repaired. Now, if it doesn't look good, if it's protruding out, if you're a swimsuit model, you may want to get it repaired even if you have no symptoms. But for the smaller ones, you don't have to get them repaired. If you're having surgery, let's say gallbladder surgery or appendix surgery, anything else that involves laparoscopy through the belly button, you may want to have it repaired at the same time and not ignore it. Now, if you do have symptoms, then that's definitely an indication for repair of an umbilical hernia, no matter what the size of it is. We don't usually recommend repair of hernias based on size. Usually it's based on symptoms. So what I recommend, also, let's review this. What are the symptoms? So you can have symptoms at the belly button. That's the most common. It can also cause bloating. That's another common symptom with a belly button hernia. However, most patients don't necessarily have pain right at the belly button. It's actually just to the side, either just to the left of it, up to 2 or 3 finger breadths away, or to the right of it, 2 or 3 finger breadths away. Not very far away, but close by. So a lot of people, and it seems like someone who's here online is saying that she had pain on the left side and started having pain in 2018 after lifting something heavy, but the surgeon thinks the pain and the umbilical hernia are separate. I would say that's unlikely. So if you have pain that's activity related, like you're saying that it's with after lifting heavy, and you have a hernia, the chances the two are related are pretty high. And specifically for belly button hernia, a lot of surgeons don't appreciate the fact that the pain is not necessarily at the belly button, it can be to the side of it, up to 2 or 3 finger breadths away from it. And I don't know why that is. I think it may be related to like the tearing effect of it. But that could be fixed by just fixing your belly button, and fixing a 1 centimeter umbilical hernia is a very straightforward, low risk operation. So if you want to consider just having it repaired and see what happens, that's very reasonable, assuming that you're a good candidate for surgery. So we have another person online that's saying that they also had a belly button hernia, but it was very painful, and it was painful at the belly button. So that's another way of presenting too. It was very sensitive. So a really sensitive belly button is not normal. You shouldn't be super tender or red or inflamed in that area. And if the belly button is super tender and it's red, that's an emergency. It can be from an umbilical hernia, in which case a repair would fix it. And then every so often, a burning, painful belly button that's red is from an infection, not from a true hernia. So that should be noted, but that's not as common as just an umbilical hernia. And umbilical hernia is more commonly seen in women, although men certainly have it as well. And it is the most common of the abdominal ventral hernia repairs. Lots of questions, you guys. I love it. Yeah, so the lady who was saying that her pain was just the side of the belly button, had the pain undiagnosed since 2018, burning pain just to the side of her belly button. That's really unnecessary. If they have, I'll bet you if they had examined her, but more importantly, if they had gotten imaging and read the imaging correctly, because what do I say? Imaging can be almost always about 3 out of 4 times misinterpreted by the radiologist, that you may have had that diagnosed earlier. She was told she should consider physical therapy. Of course, that's not going to help it. Physical therapy will not do anything for an umbilical hernia instead of surgery. And again, a 1 centimeter umbilical hernia is a very low risk operation for most people. She was told that perhaps she was overweight, which she wasn't. So the way to know if you're overweight, there's a calculator, that's a BMI calculator. Just write BMI calculator, it'll come up. You put in your height and your weight, it'll calculate something. If you're over 25 kilograms per meter squared, that's considered overweight, even though you may not think you're overweight. And yep, there we go. Man, I'm good at I've seen so much of this. I know exactly your story. Yeah, sounds like she had a CT scan in 2019 and it was missed. What did I tell you? I am right. You just see enough of these. It's the same story over and over again. Is that silly? The surgeon thinks it was muscle strain. You don't get muscle strains around your belly button. Her BMI is 24, so technically she's technically normal weight. So thank you for all of that. Thank you for all of that. Okay. We have another gentleman that's calling in or writing in saying that he had a very sensitive belly button. His was repaired 2 years later. And I'm curious how you're doing. And also I'm curious what kind of repair, because we're going to be discussing your repair options. There's a lot of repair options for umbilical hernias. Okay, here's another discussion. During fistula takedown, I assume that's an enteric fistula takedown or intestinal fistula takedown. The surgeon noticed I had an umbilical hernia and repaired it. Being that I didn't educate myself on the appropriate care of it, it recurred twice and now a third one. And I have 2 pieces of mesh that you have diagnosed they have torn away from their place and need removal and replacement of a larger mesh. Okay, this is very important. It's one of the topics I wanted to discuss, and I'm glad that one of the viewers brought it up. So repair of an umbilical hernia is straightforward. However, you have to have the right repair. So what I see often is someone who has a lot of risk factors. They cough, asthmatic, COPD, nicotine user, obese, diabetic. They have a relatively small hernia, 1 centimeter, 2 centimeters. Let's say 1.5 or 2 centimeters. They have a non-mesh repair, just a couple stitches repair. That tears immediately. You know, they're just too much tension on that repair. They're coughing. They're use nicotine, which means they're not going to heal correctly. Their collagen is destroyed. They're obese, which means it's pulling on the tissues. So now that what started as a 1 or 2 centimeter hernia is now 3 centimeters or 4 centimeters. They go back to the doctor. They may do another tissue repair. They may ask, I don't want mesh. Or maybe they went to the emergency room and bowel got stuck to it. That's how they knew it recurred. And so now they can't really get mesh. They got another tissue repair. That tears. And now it's a 6 centimeter or 8 centimeter hernia. To the point where they keep, and then they get a mesh repair. But it's done open or maybe laparoscopic, but with too small of a mesh. And so that tears. So now it's 6 or 8 or 10 centimeters. They go back in, laparoscopic, they put in a bigger mesh, they tack it to the first mesh, which doesn't work, by the way. Mesh doesn't stick to mesh. So it's like adding paper to paper. Unless you staple or glue it together, those two are not going to stick to each other. And then now they have multiple pieces of mesh in them, and it's not an adequate repair to begin with. So then that recurs. So now you're 5, 6, 7 operations in. You keep losing muscle tissue each time because the mesh never tears. The suture never tears. It's your muscle and your fascia that's tearing. And now you're stuck with this huge hernia. Guess what? You're still smoking nicotine. You're still diabetic. You're still obese. You still have your uncontrolled COPD or asthma with the cough. And Now you have an enormous hernia and you're a horrible candidate, and you may come and see me because now you're tired of it, and I'm going to say no surgery right now. We got to control your diabetes. We got to get you off the nicotine. You have to lose weight. You may need surgery even to lose the weight. We got to get your asthma under better control and your cough under better control. And then we're going to do a huge abdominal wall reconstruction. But by that time, you caused so much damage to your tissues. You have wasted a lot of time and money and time off work probably for all these operations. So I wanted to kind of tell you that even though I always like to say umbilical hernia is my favorite operation because it's short, it's small, it's cute, it's low risk. If you don't do it correctly, it's a disaster. And I really, really highlight that. So going back to our original patient with that issue, he's not diabetic and he doesn't smoke and he did lose weight. So that's very, very good. The weight is the most important part. And the other gentleman who had the very sensitive umbilical hernia now says that it was repaired a couple of years ago. And let's see, it was the belly button, couldn't even touch it at the time. How can they use mesh repair? How can they use mesh repair a hernia if imaging is not going to show problems? I don't know what that question means. If you can repeat that for me. My surgeon is recommending PT as well. PT doesn't do anything for abdominal wall hernias. It wasn't, okay, so just to clarify, it wasn't mesh repair. I felt 7 or so sharp poke-like pains, and I've been hurting ever since, which means you tore through. Those sharp pains are you pulling suture, kind of like piano, like violin strings or guitar strings through your abdominal wall muscle, and you're tearing through it. And you can have a recurrence because of the sutures pulling, or just chronic pain because constantly pulling. So the explanation I give is, I don't know if any of you wear watches that have like a metal bracelet to it. So it comes men's or women's. That sometimes what happens is that watch can kind of pull on a little hair on your wrist. Or those of you that wear glasses, sometimes the hinge of that glass can pull on one of your hairs. That's so painful. You just want to like take that watch off or take those glasses off because like one little hair is pulling. It's the same process when you're tearing through the abdominal wall. You're cutting through it with the sutures that are cutting through this. And oftentimes it's because the repair is too tight. It's like wearing a tight outfit. You're going to tear through it. The buttons will pop off. So when it tears like that, depending on the reason for your repair and how it was repaired, then there's not much you can do because it's constantly tearing, it's constantly pulling, and it's already on tension, so it's not going to be taken off tension because now it's torn through. So thank you for liking my analogy. I love a good analogy. Yeah. Oh, going back to the second patient we're talking about, imaging is not showing anything and the surgeon doesn't know what to do. So the surgeon recommended physical therapy, losing weight. I would recommend getting another opinion because I'll bet you that imaging does show something. Because what I tell you, I always say imaging's misinterpreted a lot. You got lots of questions today, which I love. So next question. Is it common after umbilical hernia repair to have no belly button anymore? Usually not. First, the surgery left me with 2 holes with a small piece of skin in between. After my recent surgery, I have only a line, like drawn with a pencil. It is so thin. So everyone's belly button is different. Some people have a little extra nubbin of skin. It all depends on how your belly button healed after the umbilical cord was cut. But pretty much everyone can have an Innie umbilicus. Every so often I see people with no belly button. I just saw a patient today who was operated on in Italy. And I don't know why, but they got rid of his belly button. So you can have a plastic surgeon recreate you a new belly button, but that's not easy. It's not common. It often doesn't look very good. So he came to me, I'm like, where's your belly button? He's like, oh yeah, about that. They got rid of my belly button. And he didn't even have a big hernia. If you have a huge, huge hernia, it's possible that your belly button is basically destroyed already at the abdominal wall. And it's hard to salvage that because the blood flow to the skin is gone by the time you need your next operation. But this wasn't even that situation for him. So I don't know why they took out his belly button. Anyway, so in answering your question, it sounds like you still have your belly button. It's a stalk. It has a communication with the muscle deep to it, but the skin around it has been kind of scarred down or something. So that can always be reconstructed or reintroduced. Is there a way to predict which umbilical hernias are dangerous, or is the main reason to operate cosmetic? So no, so the painful ones are considered dangerous because it's painful because it's being stuck or pinched. So those we recommend repair. Of course, we don't know of those people how many of them will need may undergo emergency surgery if they don't get repaired. So that's hard to know. There's one cool study that showed, if you look at the imaging, the neck of the hernia is kind of the hole at the fascia level, at the muscle level. And then the head of it is how much content has protruded through the neck. So if the ratio of the of the head to the neck is 3:1 or greater, then the chance of incarceration or something getting stuck is higher, and therefore the chances of needing urgent surgery is higher. So that's one way to look at it. There's plenty of small hernias that also have that 3:1 ratio, so I'm not saying that that's like the perfect scenario, but if you have pain or if you have a 3:1 ratio of the head to the neck, so the amount of content that's gone through versus the hole through which these things have gone through, if the ratio is more than 3:1, then you can, I recommend you have it repaired. The main reason is not cosmetic. In fact, the only time, first of all, no hernia is considered cosmetic surgery from an insurance standpoint. All hernias are considered medically indicated to be repaired. That said, the true indication for repair for most hernias is if you have symptoms. So if you don't have symptoms, you can do what's called watchful waiting. I no longer have a belly button. The mesh removal surgeon said saving it would increase the risk of a failure. Is that true? Okay, so saving a belly button sometimes causes skin and tissue necrosis and failure of the wound to heal, but no, it doesn't cause you to have a higher risk of herniations. I don't agree with that statement. Can you sew mesh to mesh instead of glue or staples? And how is that effective when you said you cannot place mesh to mesh? So if you're in there for the first time or for the original time, and you have a fresh piece of mesh with another fresh piece of mesh, and you sew that together because your hernia is so huge that you need two meshes together, which is nearly never, then that will work. Understanding that it only works because the way mesh works is when you put it in, it causes an inflammatory reaction. When it causes that reaction, that inflammation kicks in and scar tissue kicks in and your body starts growing into this mesh. My point is, if you've had mesh before, after it's already gone through its initial inflammatory stage, it's no longer inflammatory, it's just sitting there like a piece of cardboard or a piece of paper. It has no more potential to stick to anything anymore. So then you bring another piece of mesh in because now it's a second or third operation. If you want that mesh to overlap with this mesh, just know that the first mesh has no reaction left to it anymore. It's done, it's burnt out. You're introducing a new mesh, which works again with inflammatory reaction and wants the nearby tissue to grow into it. Well, if the nearby tissue is mesh, it won't grow into it, no matter what you do. And if you try and sew mesh to mesh in an overlapped way, so on top of each other, that sandwich will not heal. It'll just be at risk for having bacteria there and or fluid there, which will then get bacteria in it. So my point is, if you have mesh in you, we tend not to put mesh onto mesh. We just remove the old mesh and put in a larger piece of mesh. By doing that, where you're adding mesh to other meshes, it's uncommon, and it often causes problems such as fluid collections and poor healing. Must a comorbid diastasis also be operated on, or can a hernia alone be repaired? Oh, that's a good question. Okay, so we haven't talked about diastasis yet. A lot of people that have umbilical hernias have it within a diastasis. That complicates things. So diastasis is a thinning of the tissue and a separation of the tissue between your two muscles. Everyone has a little bit of tissue between your left and right six-pack or rectus muscles. That's normal. It's millimeters to maybe a centimeter wide. If it gets to be more than 1.5 to 2 centimeters wide, that's a diastasis. You may have seen men that have kind of rounded beer belly. That's a diastasis. You've seen women that used to be flat and had a couple kids and now they have a rounded belly. That's a diastasis. So since that middle portion is thinned out, it's a higher risk to getting a hernia there, especially at the belly button level. So what do you do in that situation? A lot of options. The simplest option is to ignore the diastasis and just fix the hernia. So that's doable, but you can't fix it like a regular hernia. You have to do what's called the Mayo Repair, and the Mayo Repair involves like a 2-layered repair because you're dealing with thinned out tissue. You have a hole now, not near nice thick tissue, but in a thin diseased tissue. So you need to do an overlapped repair called a Mayo Repair. So, but it's doable. The recurrence rate is always higher, regardless of what technique you use, if you don't address the diastasis and you just fix the hernia. But it's an option. The most drastic option is to get a tummy tuck, or what we call abdominoplasty, which addresses the hernia and the diastasis. It's also the best repair for any type of hernia that's within a diastasis. Now, true abdominoplasty or tummy tuck involves removal of skin. So if you don't have skin, then what we do is we do a laparoscopic or robotic plication of the diastasis and the hernia. So, that's kind of my 2 cents on it. What kind of, and I believe we've discussed diastasis repairs with, and hernias and abdominoplasties with 2 of our prior surgeons, one with Dr. Fisher and one with Dr. Oh, maybe 3. One with Dr. Janice and one with Dr. Nabadian. So 3 plastic surgeons we have so far. We'll have more plastic surgeons coming up this year. And the discussion has been on abdominoplasty and hernia repairs related to that. So it's a good question. But again, not everyone needs to have a tummy tuck. Not everyone's a good candidate for it. And therefore, there are other options. It's just, what's the risk-benefit ratio? What kind of mesh are used for umbilical hernias, and what is your preferred placement? So, another good question. Really, any mesh can be used for umbilical hernia repairs, especially if it's permanent mesh. There's a trend towards absorbable mesh, which I haven't really fallen into yet because the data still is not where I want it to be. So Depends on the size of your umbilical hernia and your past medical and surgical history, but you can do an excellent repair retrorectus. You can do it laparoscopically, you can do it robotically, extraperitoneal, you can do an onlay repair. These are all like different techniques. The best repair is based on the size of the hernia, what's going on inside your belly. For example, if you have a Crohn's disease, I would not do a laparoscopic or robotic hernia repair. I just don't want to be inside your belly when you have inflamed intestines. Whereas if you have a smaller hernia, let's say 3 centimeters, and you need mesh, then that's a perfect laparoscopic repair. So it depends on your body size, your risk factors, your medical history, and also, of course, your surgeon's skills to do all those. All right, let's go back to more questions. Can you recommend a surgeon in Chicago? So all of those questions can be answered on HerniaTalk.com. You can just search for Chicago and see the surgeons that pop up. Second opinion surgeon doesn't see anything definitive as well. Recommends pain injections. Yeah, so pain injections may be useful because if you're tearing and there's no actual hernia, so this is a situation where belly button hernia, very sensitive, is repaired with mesh. 2 years later, it's very painful, but the imaging doesn't show anything. So if it's torn but there's no actual hernia, then you may have to just placate the pain with injections. If it's still torn and it's too tight of a repair and that's why you have pain, you can consider Botox. So it's kind of a unique way to address it, but Botox will loosen up those muscles and therefore you won't feel the tightness of the repair anymore and give yourself a little bit of a breather. And if that works, then just do Botox a couple of times and that should loosen up the abdominal wall a little bit. That said, Botox is not covered for this. You'll have to pay cash for it usually. Yeah, my surgeon recommended pain management injections too, except you actually have an umbilical hernia. So no amount of pain injections will help an umbilical hernia. Okay, so sounds like I have an umbilical hernia that can cause referred pain on the left side. That's true. It's a 1 centimeter hernia based on imaging, correct. I am an ex-smoker. Like occasional, have not had a cigarette since the summer. Can I still do the surgery? So we don't like you to be exposed to nicotine for at least 6 weeks before surgery, and preferentially not at all after surgery. So if you can do that, you will have the best outcomes. Not a heavy smoker, just social. Yeah, but the problem is that the nicotine kind of messes up healing. And for hernias, it's something like 7x or something, where the recurrence rates and complication rates are 7 times higher than the average patient. So you don't want to mess with that. Is mesh better or suture for a 1 centimeter hernia repair? So that's an interesting question. What's your definition of better? If you look at all the data that's been published on hernias, every single one, I don't know of a single data point that doesn't show mesh to be better from a hernia recurrence standpoint. So even a 1 millimeter hernia does better for recurrence than with mesh than without mesh, all the way up to bigger ones. That said, the recurrence rate is really low for 1 centimeter hernias. And so if you come to me and you're not overweight, you're not an active smoker, you're not diabetic, you don't have a chronic cough, you're not immune suppressed, in other words, you're a low risk patient, and a 1 centimeter hernia, I would do that without mesh for sure. Even up to 1.5 centimeters, I would push that envelope because there are risks with meshes. You can get a mesh infection, you can have chronic pain from it. It just complicates things. What if you need another surgery in the future for your gallbladder or appendix, or you get colon cancer and you need surgery? That mesh is going to be in the way. So I'd rather not do it for a small hernia, even though technically the risk of recurrence is higher without mesh. Next question. I have a 12 by 12, I assume centimeter, mesh put in place for a ventral hernia has been causing lots of problems, the main one being pain. My doctor who put the mesh in now wants to take it out. Should I trust the same doctor to take it out? Well, if it's any of the doctors that I've been interviewing, I would trust them because I only pick the best. And I don't just willy-nilly interview anyone. I interview people that are well known in the hernia community, are well established in their knowledge base and technique. That said, I would always get a second opinion regardless. It's surgery, and in your case, it's repeat surgery. So even patients that come to me, I encourage them, go talk to another surgeon and get another opinion. Run that by me if you want to kind of have a bit more insight into your disease process. So yes, do see a second opinion. And then the question is, why is it causing you pain? Is it causing you pain because it's balled up? Take it out. If it's causing pain because you've recurred, fix the recurrence. It's not a mesh problem. If it's causing you pain because it's put in too tight, that's a technical problem. That's not a mesh problem. But you do have to undo the tight repair and redo it. If it's causing you pain because you're somehow reacting to it, of course, take that out. But in most cases, pain alone is not an adequate diagnosis. I need to know what kind of pain and what situation, and then based on that, make your decision. Food collection and what? I don't understand that question. Thanks so much for your videos. So nice to hear someone with real knowledge experience. Oh, well, thank you. I do have real knowledge and experience. Women doctors rule. Oh, I like it. Actually, based on that, did you see the new paper that came out where it looked at men doctors, women doctors, male patients, female patients, and it showed that basically if you're operated on by a female patient, by a female surgeon, regardless of your sex, you're going to do better. But if you're a female being operated on by a male patient, you're likely to do worse. Did you see that? It kind of supports that women should be surgeons. Okay, HerniaTalk.com, yes. Okay, so going back, all those injections did nothing. That makes sense. Okay. And yes, you agree to stop smoking forever? That's great. Wow. If I can affect you just by talking to you and have you stop smoking, that's great. But you just have to know, I see people with such preventable problems that if they just didn't smoke, they would have healed, they wouldn't have recurred, they wouldn't have had the wound breakdown, that little fluid that comes out, then it got infected, now they have mesh infection and so on. So you're doing the right thing. My surgeon said he wouldn't know if he has to use mesh until he opens me up. I would get a second opinion. You always know because you have imaging, and if it says 1 centimeter, why would you should just know in your practice if it's a 1 centimeter hernia, do you use mesh or do you not use mesh? If there's a diastasis, some people prefer to use mesh because it's so thin tissue there. So all of that's available on imaging. You're finishing up with your comments on diastasis. Yes, so diastasis is different than an umbilical hernia. And I say that because a lot of people, they mistake having a diastasis and having a hernia. It's not a hernia. It is actually just a weakness. A hernia is a hole through which things go through. So it makes you higher risk for having a hernia there, and it makes you a diastasis makes you higher risk for having a recurrence of your hernia, but it's not an actual hernia. Alrighty. Having a really hard time finding a surgeon here. Well, here's what you need to do. Do what's called a telehealth consultation. or online consultation. Many of us offer you an opportunity to do a consultation even though you're not in our town or not in our state even. So that's really what I need you to kind of focus on is at least get a second opinion, either in your state or outside of your state, so that you can get a little bit more direction. Next question. Do umbilical hernia repairs take longer to heal than other ventral hernias elsewhere? No, pretty much not. If you do not, in fact, the reverse may be true. Umbilical hernias repair really well. Yes, in your question, I am available for online or telehealth consultations. Just contact my office. All the information is on my websites. Next question. If you do not overlap old and new mesh, but rather just sew them together, is that viable to avoid trauma of removing old mesh placed years ago? No, it is not. My 12, and don't be worried about the trauma of removing mesh. There's not that much trauma in removing mesh. In extreme cases, if there is, then they would leave the mesh alone. But usually, at least in my case, I don't do that. I don't leave old mesh in and just do a crappy repair around it. My 12 by 12 mesh has caused me a lot of pain, but after several weeks, it's getting better. I was told it would take about 3 months. The rib pain is the worst. Okay, so rib pain from a mesh repair has to do with the fact that most likely they put the mesh, they sewed the mesh to the ribs. You're not supposed to do that. There are certain situations where I would do that. Hernia repair is not one of them. So in some situations, people put mesh directly over the ribs. And what happens with that is if you take a deep breath in, it hurts. If you raise your hand to brush your hair or to shower and wash your hair, it hurts. If you raise your hand to go pick something up from a cabinet, it hurts. So those are all situations where you're trying to expand your ribs and the mesh won't let it happen. Also, the muscles over your ribs are trying to move and the mesh won't let it happen. So because of all of that, it hurts. Now, in many situations, it'll get better. I do agree that by 3 months, you should feel better than at 7 weeks. So it's obviously, I would not jump into removing your mesh very quickly. How do you safely undo a suture repair if it's too tight? Okay, so if a suture repair is too tight and you have too much pain, you likely are tearing. In which case you would have to go in there, undo the sutures, and maybe add mesh because then the mesh will take some of the tension off, or do some other type of tissue repair. Going back to the ribs patient, if the mesh is sewn to the ribs, is mesh sewn to the ribs for abdominal wall reconstruction? Usually not, but I've seen it. And in those cases where it is sewn to the ribs, it can cause pain. So that's my situation. All right, let's go back to my slides. I had some questions pre-prepared for you all to see if it can help you. So what is an Outie? Do we discuss this? So an Outie is a protrusion in the middle of the belly button as opposed to an Innie. There was some discussion a couple of years ago how to spell Outie. Is it O-U-T-I-E or O-U-T-T-I-E? I was spelling it with 2 T's for the longest time, and I just feel like it should be 2 T's, but I'm told it's only 1 T. Do all umbilical hernias require mesh? So the answer is no. In my practice, it has to do with the patient and the risk factors and the size of the hernia. So an umbilical, in my practice, an umbilical hernia under 1.5 centimeters, I typically do not put mesh in. An umbilical hernia outside of over 1.5 centimeters, I typically do put mesh in. If you're super thin, I may take that number up to 2 centimeters. So I wouldn't put mesh in for a hernia up to 2 centimeters. Understanding that that decision is actually giving you a higher risk of hernia recurrence than if I did put mesh in, but I'm buying that risk against the risk of having mesh-related problems and complications. Is laparoscopic better than open? I thought someone would be asking me that, but no one did. So, no, laparoscopic repair is not better than open. A good laparoscopic repair and a good open repair are both great. A good laparoscopic repair is better than a bad open repair. And a good open repair is better than a bad laparoscopic repair. So it all has to do with the size of the hernia, your own body habits, and also your medical history. And whether or not there's a diastasis and some of the factors to determine whether you should have something done laparoscopically, robotically, or open surgery. Going back to the patient with the rib pain, you mentioned improving from 7 weeks to 3 months post-operatively. What happens during that time period that leads to improvement in pain? So what is, it loosens up the interaction and the scar tissue between the mesh and the ribs, loosen up a little bit, and you end up not pulling on it as much. Can a laparoscopic operation for appendix result in an umbilical hernia repair? Yes, any laparoscopic operation that involves a scar in your belly button can cause a hernia there, because that actually is no longer an umbilical hernia. It is what we discussed earlier, an incisional hernia. Incisional hernias are different. All incisional hernias, except for the like super small ones, all of them should be done with mesh, because you already failed a primary closure or suture repair, which was presumably done at the time of your operation. So yes, appendix, gallbladder, ovary surgeries, all of those involve an incision through the belly button. Sometimes that incision is not closed at the fascial level, so you have a higher risk of hernia there. Sometimes they're removing something. They remove the prostate, the appendix, the gallbladder, the ovary, the uterus through that incision, and that can make the incision a higher risk for a hernia. How common are umbilical hernias compared to inguinal or incisional? So we discussed that earlier. 2/3 to 3/4, almost 3/4 actually, of hernias are inguinal. The rest are ventral, and the majority of those are umbilical. That rest of that 1/4, the majority of those are umbilical. And the umbilicals are more common in women than in men. Yeah, excruciating pain with the ribs. My surgeon did not offer laparoscopic. Okay, so if they didn't offer it at all, if you asked for it and they said, oh yeah, I offer laparoscopic, but not for you, then that's kind of a tailored approach. For whatever reason, your repair was deemed to be better done, not laparoscopically. But if they didn't offer it because they don't know how to do it, then you should get a second opinion. Because in my opinion, if you're not able to do laparoscopic, robotic, and open surgery, then you really can't consider yourself to be a specialist in hernias, because you should be able to offer all options, mesh, non-mesh. You should be well versed in a variety of ways of doing things. So you should definitely seek a second opinion. I've had an oophorectomy in the past and gallbladder removal. Both were done laparoscopic. Okay, good. I've also had appendectomy age 7, oophorectomy later years. So I oddly had gotten the hernia. Yeah. Okay, so this is the 1 centimeter umbilical hernia in patients that's had a laparoscopic, oophorectomy, laparoscopic, appendectomy, laparoscopic cholecystectomy. 100% it's from your laparoscopic surgery. Yeah, for sure. Not even 99%. If the mesh is by the sternum or the ribs and was unbearable at first, but a little bit better now, 15 months later, if non-active, should I still seek removal or repair or leave it alone? Well, it depends on your lifestyle. If your lifestyle is an inactive lifestyle and you have no more pain, I'd leave it alone. But if it's preventing you from doing things that improve the quality of your life that you enjoy, then I would get it addressed. And mesh removal is not a big deal over the ribs. I mean, all surgery is a big deal, but in the grand scheme of things, it's not that big of a deal. A month after my umbilical mesh was placed 2 years ago, I developed hip bursitis and nerve weakness in my legs. The mesh was removed after 7 months. The symptoms have been chronic. I'm finally diagnosed with L5S1 nerve weakness recently. The MRI shows a bulging disc. Seeing that symptoms start within weeks after the mesh, are there any way these things are related? No, I treat a lot of patients with mesh-related complications, sciatica, L5, spinal disc problems, and hip bursitis are not related to hernias or to mesh-related problems. Does having an umbilical hernia increase your risk for other types of hernias in the future? So having any hernia indicates that you already have a predisposition towards hernias. We've discussed before how hernias can be genetic. It has to do with the collagen ratio in your body and so on. And therefore, yes, if you have an umbilical hernia, the chances are you may also get an inguinal hernia, or if you have surgery, you will have an incisional hernia. Thanks for all your info. So important for those who can plan their surgery. Yes, that's true. When going to the emergency room, they do not use mesh, and you have one surgery after one another until you get the mesh. Okay, let me break down what this viewer is trying to tell you. Remember my story earlier about belly button hernias and how it's important that it gets done well the first time? If you ignore the belly button hernia, and every time you need surgery, it's because you ignored it, and now you have an intestine stuck in it, and it's an emergency, you're never going to get the best repair. And that's going to recur. The chances are you won't get mesh because you have bowel injury, or you won't get a surgeon who does this for a living, so you won't get the best repair. And you probably aren't ready yet for surgery because your nutrition is not optimized, and you're still smoking, and you're maybe overweight. So all of those scenarios make it so that people that undergo umbilical hernia repairs emergently do horribly compared to patients who get it done electively, because they will get recurrences, wound complications, need a second operation. So I'm not saying everyone should have surgery, but if you have a higher risk hernia, such as one that's tender or painful, don't ignore it. Get it done electively so you don't end up having it done emergently. I had new mesh sewn to old mesh. What complications do I need to look for in the future, or should I have a revision before complications? So what's done is done. You should never prophylactically undo a hernia repair, because the chance of you having a complication are not 100%. Just wait. Typically the scenario is you either get a recurrence, number one, or you get a fluid collection between the meshes, which can cause pain, and or that fluid collection can get infected, in which case you'd have to act upon any of those three scenarios, but I would not prophylactically undo anything. If the old mesh was described as incorporated into the external oblique, what does that change? Does that change the equation as to whether new mesh can be sewn into this incorporated external oblique? No, it must be incorporated, because that's how mesh works. What you want is the new mesh to incorporate, and if you put it against other mesh, it will not incorporate, because mesh does not incorporate onto mesh. Mesh is the tissue that incorporates into the mesh. So if you don't put the mesh against tissue, it won't incorporate. The issue isn't the first mesh. The issue is trying to get the second mesh to work. So you don't need a third mesh. Let's see, lots of good questions. What is this question? Okay, my belly button little hernia, which is after her laparoscopic umbilical appendectomy, cholecystectomy, and nephrectomy. The belly button did not start bothering me until 2018, 7 years later. Yeah, that's true. That's the natural nature of all hernias. You get it, you don't know you have it, and then months, years, decades later, it'll cause symptoms, and many people never causes symptoms. 7 years later, so not from lifting, but lifting could have caused it to get worse. Possibly, most likely not. It's just a matter of what's going on with the rest of your symptoms. If you have a chronic cough, if you're constipated, or if you're overweight or using nicotine, those are more likely to making it worse than any sort of lifting. So if it is laparoscopic related, should they repair with mesh or suture and laparoscopic or open surgery? Yeah, so if it's incisional hernia and it's 1 centimeter, I would use mesh in that because otherwise the recurrence rate is almost 50%. With regard to Texas, I live in Texas. Do you have any colleagues you can recommend? Thank you so very much for all you do. You're welcome. Again, go to HerniaTalk.com and just search the word Texas or your city and see if anyone's recommended surgeons there, or if you like any of the surgeons. I honestly don't know that many surgeons in Texas. There's maybe one. And it all depends on what you need. So Texas, I've actually considered like going to Texas, you know, to do surgery, but I'd rather you guys come to me because I have my whole team here and it's a bit more difficult for me to travel and see you for like a week and then not see you afterwards. Pregnancy. No one talked to me about pregnancy. Can I still have pregnancy after umbilical hernia repair? The answer is yes. If you've had an umbilical hernia and it was repaired before you're done having pregnancies, obviously I'm talking about women, then there's a higher risk that your hernia will recur. And if you had a mesh repair, it's a higher risk that during pregnancy you'll have chronic pain in that area. Of course, it's not 100%, but it's something to be wary about. So if you're female and you have an umbilical hernia and you plan to get pregnant and you don't have like no symptoms, don't get your belly button hernia repaired until you're done with pregnancy. That's the safest bet. Do you use glues, staples, or sutures for incisional hernias? I do not use glues or staples. I do suture my incisional hernias. Should I wait to lose weight for an umbilical hernia? This is a leftover question from last week or 2 weeks ago. Yes, as we discussed earlier, you don't want to have a poorly done umbilical hernia because the domino effect will make you have a giant hernia because you'll keep tearing through it. And each time you tear, the hole is bigger. You end up with a more difficult hernia to repair. Because first, the hole is bigger. Secondly, the tissue is missing. So you have less healthy tissue to deal with. And third, you probably still need to lose weight. So yes, absolutely lose weight before you get any umbilical hernia repaired. Come to Texas. Yeah, I should come to Texas. You got to come to me. Will you come to Chicago? I have come to Chicago for meetings and Texas for meetings, but not to start to operate. It was really heavy and started feeling bad the next day. All right, a couple more questions, you guys. What if I don't repair my umbilical hernia? So that's a good question. Watchful waiting is considered safe for umbilical hernias. We don't know about that for ventral hernias. However, we know for really big hernias, if they're 9 centimeters or larger, that people have a much better improved quality of life if they just have a damn hernia repaired. The smaller hernias, we also feel the reverse. If you don't repair the really small hernias and they're considered low risk, then you should just consider non-surgical approach and don't be constipated, don't have a chronic cough, don't smoke nicotine, correct your diabetes, and get your weight under good control and exercise. So if the hernia, however, is symptomatic, which means you have burning, sharp, dull, any type of pain in the area, then you really should get it repaired because the chances are that the pain is telling you that there's something stuck in there. And if you don't address that, that thing that's stuck will cause a lot of symptoms and pain and then obstruction, and you'll need emergency surgery. All right, everyone. It was fun. That's a very quick hour, super quick, tons of questions. I love that so many of you were involved. I knew sometimes, you kind of forget talking about such simple questions like umbilical hernia, but I knew this would be a hot topic. You guys went through some amazing scenarios. I love answering all those questions. Many of you are looking for surgeons near you, so please go to herniatalk.com to look for surgeons that we talk about, or go through my kind of list and see who I've interviewed on Hernia Talk Live. Also, the American Hernia Society has its own website, which has a series of list of doctors that you can go find a surgeon. So thank you for joining me. Come back next week, every Tuesday, Hernia Talk Tuesdays. I will be here and will answer a lot of your questions. Thank you so very much.